Good afternoon, and thank you for joining us. My name is Lee Montville, and I'm with Springer Publishing Company, and we are thrilled to have you join us today for our publishing webinar series, Adverse Childhood Experience, A Troubled Memory Lane, How ACEs Affect Residents in Nursing Home, presented by Elise Beaulieu, who is one of our authors. If you have any questions for Elise during the presentation, please put them in the Q&A and we will ask them at the end of the presentation. In addition, we will be providing information at the end of the presentation regarding a special offer for a discount off of Elise's new book. We are thrilled again that you have joined us today, and without further ado, here is Elise Beaulieu.
Hi, everybody. Welcome and thank you for joining us. And I want to also thank the Springer team for making this possible. It's been a real pleasure working with them. They're wonderful people, and I've been very impressed with them. Adverse childhood experiences. This is also known as ACEs. Social workers are often the first in the nursing facility to have the opportunity to hear about an individual's early years and any trauma that may have taken place there. Sometimes this information is couched in statements such as, I had a rough childhood, or I grew up in foster homes, or I can still remember in detail what happened to me. Some residents are reluctant to talk about their past experiences because they may feel guilty, embarrassed, or ashamed of what happened to them. Asking neutrally phrased questions may help elicit more in-depth conversations, such as, that sounds like it was hard for you. Have you ever talked to anybody about these experiences? Trauma can leave a person feeling it was their fault or embarrassed that they haven't gotten over it. Aging in itself can prompt unbidden memories, some of guilt, others of unfinished business. Opening the conversation provides the opportunity to offer assistance, counseling, determining if there are any triggers that may hinder their care in the setting. The chapter in my book covers this important topic because of the frequency that I've encountered these particular circumstances. So I've had about 40 years of experience with older adults in a variety of settings. I've worked with people in nursing homes. I've worked as a counselor in nursing homes. I've worked in housing, adult day health, and all of this brings to bear the understanding of what happens to folks in early childhood can be lasting trauma, and how important it is that we take a look at that. So some of the goals that I hope to achieve during this webinar with you are that you're going to be able to define adverse childhood events, or ACEs, explain how ACEs can contribute to behavior challenges in the nursing home setting, and identifying care that minimizes triggers. For the nursing home resident, experience of a past trauma can be reignited by their physical illness, disability, hospitalization, and placement in the skilled facility. Initial assessments can help identify these key stressors through gathering and highlighting these events. SAMHSA defines trauma as resulting from an event or series of events or circumstances. These include physical, emotional harm, or life-threatening events that have lasting adverse effects on the individual's functioning, physical, social, emotional, or spiritual well-being. Expanding our list and linking trauma to the ACEs, the Centers of Disease Control and Prevention report that adverse childhood experiences are rather commonplace. Approximately 61% of adults surveyed in 25 states report some type of ACE. ACEs are potentially traumatic events that occur during childhood from birth to age 17. That's what we include that catchment. They can include physical abuse, emotional abuse, sexual abuse, household mental illness, household substance use, household domestic violence, incarcerated household members, parental separation or divorce. The increased risks for developing troubled emotional closeness with a family when a person experiences greater numbers of ACEs occurs as well. Fractured family relationships lead to limited or no formal care and support for the older adult, and this increases loneliness and isolation. When a person experiences multiple ACEs, they are at risk for developing troubled emotional closeness to the family. This can include periodic or permanent estrangement between parents and children, poor rapport or no contact with extended family members such as aunts, uncles, and cousins. Let's take a look at a case example. This case example is from my own practice. The name and age and other identifying factors are changed to maintain confidentiality. May Jones, age 94, was a widow when she was living in a nursing home and she presented with depression. She had decided that she wanted to finally address some questions regarding her early life experiences. I just want to know why I stayed. She described her early years as being very difficult. The family was poor. She and her mother lived with a grandmother and two uncles. Her father had abandoned the family shortly after May's birth, and her mother worked in a local factory to support the family. When she was 6, her mother remarried and continued to work. Shortly after the marriage, a fire occurred in the factory. The building collapsed and killed her mother and other workers. Almost immediately after her mother's death, her stepfather evicted her grandmother and the two uncles. She related that she did not have contact with them following the eviction. Her stepfather molested her within hours of her mother's death, threatening to send her to an orphanage if she resisted. He regularly pointed to the orphanage across the street, reinforcing her orphan status and not leaving her many choices. He said that that's where she would go if she didn't cooperate. When she was 12, her stepfather remarried. So she and the couple, her stepfather and stepmother, lived together. They never had children, and she lived with them until she married a widow with 2 sons at the age of 36. During her years with her stepfather, Ms. Jones completed her education, including going through a secretarial program after high school. She had a successful career working in a law office. Now, she presented as a very strong woman. She had an upright posture and a firm way of speaking. She had never shared her life experiences with anyone. She recalled vivid details of the molestation, her confused feelings and fears as a child, and her worries about going to the orphanage. In this situation, her life experiences included several ACEs. She and her mother were quite poor. There was early abandonment of her father that left the family impoverished and her mother working in a dangerous factory. Although there appeared to be some additional supports in the household, the grandmother and the uncles did not seem to mitigate circumstances, and she was denied their care, particularly after the eviction. So there were a cluster of adverse events and sudden parental loss, socioeconomic loss, the beginning of her stepfather's emotional intimidation and sexual molestation. We call that childhood sexual adverse situation. Her life improved, and however, with him, her life improved. She had household stability, her stepmother, and she asked why she stayed, particularly after she had her own economic security. So we'll take a look at some of the qualities here as we go through the next slides. And what were some of her strengths? Okay, we want to really take a look at that. She, at 94, she had cognition and memory. She was able to verbalize her concerns. She had finished her career in school. She had also made her, she presented with some resiliency in order to maintain her quality of life. She had made some decisions to stay for a while in the household. The difficulties that she had, she was abandoned by her father. She lost her mother in a tragic accident that she could recount in detail. Lack of support from her grandmothers and uncles, emotional and physical abuse, sexual molestation. Older adults who come to the nursing facility are facing challenges of increased physical dependency. They may be recovering from surgery or falls and other chronic ailments. These situations can contribute to the individual's desire to understand what happened to them earlier in life, to put some sort of perspective on it. How can they reclaim their independence and utilize their life-learned skills to regain their former homeostasis that they had in the community? Is that possible? She liked to go for walks, she liked to read, and she also was very able to give voice to what had happened to her, which she hadn't in her whole life. So how do we evaluate these experiences? And we're going to take the perspective of risk and protective factors. Risk and protective factors. A protective factor speaks to the strength of the individual and the circumstances that can mitigate challenges. Risk factors include the circumstances and events that happen to the individual. By weighing risk factors and protective factors, we can learn how the person has coped in the past. As we noted earlier, the more risk factors, including multiple losses, poverty, multiple events that are combined, create greater risks. At the same time, when we weigh in factors that are protective, supportive, we may find that they provided hope and respite from the adverse situation. These can include the person's own resiliency, successful learning and coping strategies, and other family members who often can offer a place to stay, nurturing financial resources, or role models. So we look at these factors, and we can see how we can help folks by supporting the protective factors and also addressing some of the risk factors that may not be risk factors for them anymore. So let's take a closer look at risk factors. What to look for. In some cases, the carefully constructed avoidance of these past experiences that may have been masked by other life experiences are there. They may have been compartmentalized or deliberately forgotten or overwhelm the person when they enter a nursing home. Illness, lack of mobility for self-care, dependency, and feelings of helplessness can trigger these memories of early childhood deprivation. And these can leave the older adult with a higher risk of poor mental and physical health. I had a person who had been tied to a bed and locked in a closet as a child by his grandmother and his uncles. And what happened was that as he was unable to care for himself in the nursing facility, this increased his stress level, and he was having terrible time with not being able to get out of bed to go to the bathroom. While he wasn't tied in bed, he was not able to get out of bed. And so that presented very, very serious stress for him. These ACEs can leave greater number of ACEs over the 4 are associated with greater risks. These include binge drinking, diabetes, stroke, depression, disability caused by increased health needs, higher inflammation levels, premature death, lower life satisfaction, and lower psychological well-being. The person may report feeling worthless, unwanted, always an outsider. And that's really important in our facilities, because we can have folks feeling isolated, and certainly with COVID, we have people that are confined to their room at times because of other contagion. So this is a really important factor to address and to help mitigate as best we can. These events of the past may trigger emotional behaviors that have served them in the past: anger, rage, withdrawal, regression to childlike temper tantrums. These behaviors can alienate the staff and serve to further isolate the individual. Staff can express less empathy or declare the person is making stuff up, particularly when the person's story of abuse or other childhood adverse events changes slightly. Some people are very open about what has happened to them, but again, the retelling of the story sometimes changes a little bit. People misunderstand, and as soon as the person doesn't keep the solid picture that the staff expects, they may have less patience with them, and may tell them, say that I think he or she is making it up. Experiences as a child have also encouraged reliance only on themselves and a great mistrust of other people. As one gentleman shared, "I don't trust people much." Okay, let's take a look at protective factors, what to look for. Higher education. While early adverse childhood events leave an indelible mark, there are protective factors that have been identified to assist the individual. For example, higher education. Education is an assist with an ACE that helps the individual improve their self-concept and offers an opportunity to have a career and attain a higher socioeconomic status. In the case of our example earlier, our 94-year-old woman, she had attained a higher level of education than she might have otherwise. She went to secretarial school, and she was able to have a successful career in a law office. That gave her some status and self-esteem in terms of her ability to do things. Social support and social integration. These two factors play an important role in assisting the person to cope with their past. Having social support and being involved and having active community roles is protective. For example, let's go back to our earlier case. She married. She had the stepsons who were very good to her. They came in, they visited, they offered her support. That's very helpful to folks. I had another woman who was badly abused, and she married and had children, and her children were very supportive. As a matter of fact, they went back to the state where she had been put up for adoption, and they helped her look for other family members. So this support is, I think, broken down in the ability to love and to accept and to be loved. And that social support and social integration is really highlighted. Socioeconomic status. That's threaded through the lives of older adults who've had ACEs. Poverty, both as a child as an adult, creates greater health risks from 15 to 20%. There's greater access to counseling and economic resources, housing, and employment and formal supports when your social economic status is not impaired. Religious or spiritual involvement can provide a buffer for older adults who've experienced early lifetime trauma and stress. In a study by Mosley, it was found that high religiosity provided a buffer against experiences of war and trauma and childhood adversities for a group of Somali refugees living in Finland. Further research has been seen with positive associations among religious and spirituality and well-being. Religion and spirituality assist in important coping strategies for persons with disabilities. They suggest that rehabilitation professionals understand the strategies to enhance religious coping and understanding religious issues. Religion can also provide the foundations for mediation with older adults who are struggling with negative events in their lives. Religion overall supports forgiveness and altruism. The caveat, of course, here is for those victims of abuse by religious personnel. But if we exclude that, then we do find that religion is helpful. Resilience. This refers to a process that individuals use to cope with difficult situations. The American Psychological Association defines resilience as the process of adapting well in the face of adversity, trauma, tragedy, threats, or significant sources of stress, such as family and relationship problems, serious health problems, or workplace and financial stressors. Inasmuch as ACEs can influence the individual's physical health, psychological and psychosocial well-being, relationships, resilience can be a powerful tool that involves recovering from the events and in some cases can provide the profound personal growth. Resilience as a response to adverse conditions can also assist with protection from the toxic influences of stressors on physical health and in general, immunity in particular. Okay, let's take a look at some of the behaviors and challenges in the nursing home setting. As we can see, there are a lot of areas that ACEs can affect, and trust is often the foundation for helping the person. And this trust can be a very fragile thread between the caregiver and the person. Trust has to be slowly built with individuals, and you want to use small steps, remembering not to promise something without ensuring it can be carried out. When I use that, I'm going to be back, I always make sure that I am back before the end of the day. If I can't be back, I will stay late in order to respond to someone's questions or a promise that I have said. I will be back at the end of the day, or I will be back before the end of the day to see someone. If you don't think you can be back by the end of the day, try not to promise that, and then you aren't stuck. It's kind of like a well-being for yourself, but it's very important. People think that's so small, but people will wait hours for your return. So, and I've heard many people say, well, they promised they were coming back, but they didn't. I don't trust them anymore, or anything that they say. As with other social work interventions, letting the client lead the conversation is key. Success is likely with understanding and compromise. Demanding compliance is going to have limited success with folks. As one resident said, I don't like being told what to do. I will do the opposite of what I am told. Asking, not telling, is often helpful in terms of care preferences. For example, if a resident refuses showers, the social worker or caregiver can ask how the person would like to get clean. Again, that's so important because the way we do it is oftentimes, it prevents anybody from having a breakdown. Touching, restraining, positioning can elicit flashbacks of helplessness and abuse. Some caregivers are more skilled at others with interventions and assignments should always take this personal preference into consideration. And we have to pay attention to some of these things because they do make a difference for us. Creating trust. Individuals who have experienced trauma may experience difficulty trusting others. It's important that the social work should create interactions that improve trust. Trust is often measured in small steps. Identify the qualities of strength in the individual. Encourage their participation in the setting. Provide consistent approval for the things that they're able to do. Encourage family to visit if they have it. Take the resident for an outing and recognize special holidays for them. Educate the staff about ACEs is also important. Staff themselves may have experienced trauma and in their lives, and this may improve their helping toward others, but it can blunt their responses. I had one staff member who failed to report a roommate throwing water over her roommate. And the staff member simply didn't see it as a problem. It was only water. So it's important for staff members to understand, in this case, the staff member had trauma in her past, but it's important that we have, we help people understand what childhood means to our residents and how their interventions may or may not be of help. Staff interventions. Okay, as we said, staff need to be sensitive to resident preferences. Social workers can take the lead with staff in letting them know the background of a resident and the need for extra attention on how care is provided. In one case, I had an example of this. A woman had a very serious gunshot wound and was in a wheelchair. And her request, when I asked what her preferences were, was staff at night turn on the light. And in doing that, she could identify the person coming into the room. And we said, of course we can do that. That's not a problem. I explained the need and the issue to the staff. And when I went back, she said staff was being exceedingly helpful, and they were always doing that when they came in at night. So it was really very helpful for her and did not trigger her in any way. Sometimes being restrained in any manner can have special meaning. For example, a gait belt may be associated with a person who has experienced wearing a backboard strapped to their back as a child. One resident talked about having a board strapped to their back. If they didn't sit up straight at the table, they would be put on the back step with a backboard strapped to their back and eat with dogs. Darkened rooms can trigger memories of being put in a closet. A loud voice, a pointed finger, harsh commands such as sit down may trigger past emotional or precludes to emotional abuse. Ensuring choice of care, going to the toilet rather than using a bedpan or a bedside commode can be an issue for someone who has been, and I mentioned the gentleman who had been tied to the bed. He didn't want to use a bedpan. He didn't want to use a bedside commode. He wanted to go to the toilet. Frequent reassurance, patience, sincere praise is very helpful, as is being respectful, trustworthy. Those with ACEs often feel forgotten and valueless. What questions assist care? We can ask questions. How can we care for you respectfully in this care setting when you hear about someone who's gone through childhood abuse or neglect? What staff approaches are helpful for you? Can you think of any triggers, lights, sounds, words, settings that we can avoid in taking care of you? What are situations that help to make you feel safe? And would you be interested in speaking to a therapist, counselor, or nurse practitioner? These questions can assist with providing the person with greater satisfying stay and help to engage the staff in providing fewer triggering circumstances. Some staff, again, are reluctant to believe a history of abuse or think that because it happened so long ago that the memories of abuse should be shed. It's helpful for the social worker or caseworker to explain that these circumstances, though diminished during active adult, reemerge in the face of health decline and increased helplessness and dependency. to summarize, what I really want to emphasize here, and this is really important, is that adverse childhood experiences can last a lifetime. Some nursing home residents have lived through moderate to severe childhood trauma. And again, we have no idea what it was like for them. I always ask when I'm speaking with a resident who's telling me their story is, what happens now to you when you remember it? In how can we help you out on this? And sometimes it's just, I just would like to talk to somebody about it. And was I wrong? Am I wrong to keep remembering this? A lot of people need reassurance for these kinds of traumas. And understanding the positive and negative factors can assist the social worker in helping these residents. And it doesn't need to be an elaborate counseling, just dropping in. You don't need a clinical hour. You can assist residents by being there for 5 or 10 minutes. In the previous brief presentation, we've addressed adverse childhood experiences, or ACEs. We have learned that these experiences don't diminish with age. In fact, life review can prompt a reevaluation of these circumstances. Older adults can and do make progress in addressing these issues of the past. In some cases, they're able to reframe their victimization and to appropriately put the blame on the abuser. And again, I hearken back to my original case when we were leaving my lady in the example. At the end of our time, she commented, "I hope he rots in hell." And I thought that was a pretty good conclusion for her. She seemed to find satisfaction with that. Greater life satisfaction, empowerment can give new ways to new thinking about the past. Indeed, determining that these events and experiences did not define them now. And success in adulthood can assist with this conclusion. So, do we have any questions?
Thank you, Elise. That was excellent. We really appreciate it. And thank you for everyone who's been listening. We do actually have a couple of questions for you. So the first question is, how do you initially approach a resident if you suspect ACEs?
Okay, one of the things that happens is that these come up in varying ways. Sometimes it's a question of you've asked a question about their education, and as a matter of fact, the other day I was with a resident and I said, "And how far did you go to school?" And he said, "Well, I didn't finish high school." And I said, "Oh, what happened?" And his response was, "I had a very bad childhood." And that opened the door to looking at what had happened to him as a child. It turned out he was one of 11 children, and he described his father as being an abusive alcoholic. And that in itself created my understanding of what happened to him and some of the issues that were going on for him. So it can be triggered by all kinds of questions. People, sometimes you say, "Well, where did you grow up? What did, how many children in the family?" Sometimes they'll say they moved a lot. That also is sort of can be a trigger. Sometimes there's a death in the family and there's chaos and abuse. So there are lots of different, there's no standard way for people to ask. I've asked common questions like, "Do you have any trauma in your life?" That doesn't in itself usually elicit anything. I have to be very honest with you. Asking people up front, "Do you have any trauma in your life?" Folks will not respond to that question. So it's usually around the corner kind of evaluation. So you
That's,
know,
yeah, that's great. Because with this, somebody had asked, what language do you use if wanting to ask a resident if they've had adverse childhood experiences? So,
yeah, I usually use what was your childhood like?
yeah,
That works very very well. Did you have a happy childhood? So that doesn't, sometimes what they'll do is they'll say yes just to smooth it over because they don't want to seem out of sorts with what kind of a childhood they had. But as you get to know the person, they can sense permission from you to share. And that's a very important thing. We have to listen long enough and be quiet long enough so that people feel that freedom to share with us information.
great. The next question was, what do you do next if you're not getting anywhere with a resident and they continue to exhibit behavioral issues?
Okay, if they're and I guess I would have to be more specific. It's what kind of behavioral issues are we sort of talking about, so that I can be more direct. Any particular item that they're dealing with, what's happening?
They didn't ask that specific.
Okay. Behavior behavior can be a range of things. Again, people can become angry. A lot of it comes from trust, or mistrust, I should say, because the person is having trouble trusting the folks around them. And sometimes what you can do is to sit down and neutrally ask, what's going on? What's happening? In a way that's open. And if it's something that's specific, such as the aides aren't doing what they're supposed to do for them, you can say, well, can you give me an example? How is it not working for you? How is it being uncomfortable for you? And what can we do to make it better? A lot of people haven't heard that. They just make assumptions that the staff should know what they should do. They should know what to do, and they play the guessing game. So I'm very honest and upfront and say, okay, what can we do to fix this? We want to fix it. We want to help, and we want to make you more satisfied. Notice I said more satisfied. Sometimes we can't fix it all.
Exactly.
So we have to level that. We have to be honest. And people appreciate that honesty. Even people with very serious mental illness. I had a woman the other night ask me, are you going to, she wanted me to call the daughter, and I hadn't gotten to it. And she said, well, when are you going to do it? And I said, well, I'll try to do it by the end of the week. I gave myself enough time to make sure that I could do it. And I also answered her question. And I gave myself enough lead time to accomplish the task. We have to be very careful if we promise things not to put ourselves into a box, and not to lie to the resident or to misrepresent what we can or cannot do. If I cannot do something, I'll be very honest and say, I don't think that's within my ability to accomplish. And I will try to accomplish it, and I will get back to you even if I don't. So that's another thing. If I'm not able to do it, then I will tell someone. And yes, I have been called useless. I had one resident call me useless. So.
Well, I have to say, people here today are so engaged. We actually have a couple more and value what you're talking about today. We have a couple more questions that I'm going to ask you. I also wanted to reiterate that We will have a special offer for Elise's book, which she just switched to that slide. So if you're
Thank you.
interested in buying Elise's book, you can get a discount using the code below. And then at the end of the presentation, we'll have contact info should you have any other questions. But there is a new question just came in from Angel. Do you think as time passes that their level of depression and anxiety increases? If so, how do you handle someone who doesn't want to help because they are close to death? Sorry for the sensitive wording.
Okay, so anxiety. Well, anxiety can be from lots of things. And again, it can be from certainly childhood experiences and adult experiences as well. Sometimes at the end of life, people are afraid. People are afraid of dying. And sometimes they feel very bereft. I don't know if this person is tied up with hospice, but I did have a man one time who was not religious, and he was dying. He was dying of a very painful cancer. It was bone cancer, and it was in his spine, and he was in a lot of pain. And he noted that he was afraid of dying, and he wasn't religious. So what I did was I did talk to hospice, and they offered a chaplain who was non-denominational and who understood that this man was not religious, so he wasn't going to approach him. But it turned out to be very successful and provided this man with some better feelings. So I might suggest a chaplaincy. Sometimes that eases someone if the anxiety is part of dying, if it's a part of their anxiety over their past. You can also use a chaplaincy, or you can also help by talking about feeling bad about past life experiences and what we might do, and try to mitigate some of the feelings of guilt. But chaplaincy is sometimes a very, and again, that religious component I mentioned is a good way to go sometimes at the end of life.
That's great. Thank you. So we have two more questions. First one is, how do you talk to other colleagues about ACEs if they don't believe in trauma?
Okay. All right. We have so much trauma. Trauma comes from so many things. Trauma comes from when people have a house fire and their house burns down to the ground, although they might escape. Trauma comes from hurricanes, tornadoes. I mean, it's just, it's phenomenal. Folks that lose their houses during war and internal conflict. I mean, it's just tremendous. It's hard to, it has to come from compassion and the term empathy, not necessarily sympathy, but empathy for someone who is going through such life-changing circumstances. And I'm not sure that we can teach empathy. I would love to say we could, but you know, empathy is something that means that you have put yourself in another person's circumstances so that you have a little understanding of what they're going through. It doesn't mean that you feel sorry for them, but you understand the circumstances. And oftentimes people are very task-oriented. And if people are task-oriented, sometimes they see the task as more important than the particularly emotional situation. You might approach somebody by saying the tasks are easier if you approach the person in XYZ manner. So you can appeal to their getting their job done. see if it works. And I think that that would be your individual will be happier with your job if you can approach them in this manner. So trauma, we can leave the trauma out, or even the adverse childhood experiences, but we can just address it from the perspective of making their job easier with a good approach. So I guess that would be my best answer for that.
Great, thank you so much. And the last question, and this I think a lot of people who are attending today and others would love to hear your opinion about, which is, what do you do about self-care if you hear a lot of traumatic pasts?
Yes, yes, trauma is pretty overwhelming at times. I've heard some very traumatic stories in my practices over the years, and some of it sticks with you. And I think the biggest takeaway that we can have is that by listening to people, we have offered them something really powerful and good. And by listening to people and hearing their stories and being witness to it, we can empower them to move forward. And that in turn validates what we do as being the conduit for improving someone's life. My takeaway is to remind myself that I've helped somebody for the moment, for the here and now. And maybe I don't, I'm not a world leader and I can't stop war or other bad things from happening to people, but for the moment that I'm with them, I have given of myself, and therefore I have done something good. And I think we have to remind ourselves that this is what we do. And that should give us some good things. Of course, going home and taking care of ourselves, getting enough sleep, getting outside, taking a breather, and also sharing it with others who can be of support to us, a supervisor or a colleague. If we share these things with those folks, we will be also helping ourselves feel a little bit better because we've kind of shared the burden a bit. But our biggest thanks is by making a difference in these folks' lives and helping. And then we can go out saying that we too have made a small difference for our folks. And that's what we can do.
Excellent. Thanks, Elise. This was amazing. We are thrilled to have had you join us and present today. Thank you to all the people that have joined us for this webinar. Again, the information about Elise's book is on this slide. We will send all of you a recording of this webinar within the next 7 business days. If anybody has any questions, please feel free. If Elise, you could switch to the last slide. If you have any questions at all, feel free to reach out. My information is there. And again, we thank you all for joining us today, and we wish you all a wonderful rest of the day, a wonderful rest of the week, and we thank you for what you do. Thanks, Elise.
Thank you. Thank you very much.
Have a great day.
Everyone have a great day. Thank you.